Welcome to the Beyond Physio Podcast, where we help you move, excel, and inspire others on your journey to your next level with knowledge and advice from experts and testimonials from our like-minded community. Welcome to the Beyond Physio Podcast. I'm Dr. Jerry Yu. On our show today, I have a very special guest, as all guests are very special, Dr. Phil Horne, who is a spinal orthopedic surgeon in the Cary area. Has quite the reputation, and what's really cool about Dr. Phil is that he's got an amazing background in athletics, which we'll talk about, and he's done his fellowship at the world-renowned HSS, correct?
Yes, sir.
Yes.
Thanks for having me.
Yeah, yes. Great to have you on the show. And I think it was really cool how we met. Very happens chance when you sort of stopped by the office and we sort of hit it off, and we had a little bromance there. And ever since then, we've been sort of text pals, so that's been kind of cool. Dr. Phil, I really want to dive into your knowledge base first, but let's talk about your background. Mm-hmm. You had some quite extensive training over at Ohio State, and that led you over to HSS and then to Duke.
That's close, yeah. So The Ohio State University, I attended that for undergrad as well as an MD, PhD combined program. And my PhD was actually in transplant immunology, but then from there chose to pursue orthopedics, which I did at Duke. So I did orthopedics residency at Duke,
yes.
Became interested in spinal surgery, and did fellowship training at Hospital for Special Surgery in New York.
Excellent. Tell me what you liked better, or what you liked better, Duke or HSS?
Well, they're great in their own ways. I think that the HSS, the hospital, the tradition there, the people are wonderful, and it was a great experience for 1 year for spinal surgery training. Duke has a lot of tradition as well for general orthopedics training, so I feel that I've had a special opportunity to train from the best in both. And coming back from New York to Durham, North Carolina for starting my career in spinal surgery at Duke has been a great initial part of my career, but as you had alluded to, I am now in the Cary area. I've started my own private practice, solo practice at Premier Spinal Surgery.
Excellent. Now, what was it, Dr. Phil, that made you want to break away from the institution to start Premier?
Yeah, that is a good question. So over years, I began to see that while there are many benefits to being in a large health system, there are also some disadvantages for patients primarily. A lot of times there'd be longer wait times, and spinal conditions can be very severe and require urgent attention. And it was always my goal to be able to deliver that urgent care and attention and get them on their treatment program without unnecessary delay. And I just saw there were more obstacles to having that kind of early evaluation possible for patients. There have been other things as well, but I realized that maybe there's a better way to do it on a smaller scale.
Yeah.
And so I thought I should try.
I like that. It's very much mirrors my own career, where I've been in very high volume PT practices where the best you can do is provide a cookie cutter approach, because between seeing 3 to 4 or 5 patients an hour, it's really hard to deliver the kind of care that we had been trained to do. And I thought that maybe there would be another way as well. And I think that you made the great choice. And I hope there are more physicians out there who do make that same choice and go off on their own, because the benefits of the patients are really amazing. I mean, you really can become a patient-centric office. And really, time spent with your clients, you can only deliver better care in most cases. So kudos to you for taking that leap.
Yeah, thank you. You as well.
Oh, thank you. So let's talk about back pain, because we see a lot of patients with low back pain. Over the years, we have become a well-known place to send patients who have back pain for a lot of physicians, only because the way that we approach care, it's a very whole person approach. And I've said this in other podcasts, where we don't just take into account the immediate issue at hand, which might be low back pain, might be sciatic, something that's either disc nerve related or structural related. It just might be that, listen, let's talk about your lifestyle first. Let's talk about where you want to go in life. Because if those aren't on the radar for us, then it becomes hard to develop a plan of care, to develop that journey for the client, to know that this is the starting point, but this is the gateway towards you as a person optimizing your life for the future. And back pain is one of those things that we can work on to get you to that goal of whatever that might be in life, which is typically why a lot of our clients tend to be over the age of 30, and active as well. How about for you, Dr. Phil? What would you say about that?
Yeah, our patients that we see come in a range. We have high-level athletes. We have some that are active in kind of home and work-related ways, maybe not athletic specifically. And then there's some that just value their more sedentary lifestyles, but want to be able to do their desired level of activity without so much pain and limitation. So I think understanding the patient's goals and trying to restore their desired level of activity is very important. We therefore try to help them within their vision and returning to that level of function in the way that's most suitable for them. So we try to deliver a personalized spine care experience, and I think a personalized physio experience would kind of go hand in hand with that.
Absolutely, yeah. That's great. Now, let's talk about causes of low back pain that you've come across, Dr. Phil, especially as a surgeon. When someone says they have back pain, what are some of the things that you're thinking about diagnostically that, hey, you know what, we got to make sure we check out for these kinds of things to see what's really causing that?
Yeah, that's a great question. So there are many types. Probably the most common type is muscle and tendon-related pain. And that could be something that comes on acutely, like I lifted something or I was doing athletics and I had a hyperextension injury with a box jump, for example, or some type of acute onset injury from lifting, bending, twisting. But there's also acute onset back pain with maybe no specific injury or athletic involvement. It can create a lot of inflammation, similarly to kind of onset with a car accident where the muscles actually get injured, causes micro tears, a lot of inflammation, and the muscle is actually dysregulated for a time. So people can't move. They have difficulty rising from seated to standing position. They have difficulty with kind of partial forward leaning activities like washing hands or brushing teeth. And that's when those muscles are dysregulated. Goals of treatment would be to reduce the inflammation, and then an important role for physical therapy at that point to recondition the muscles, kind of retrain them to work with the person and their function, and instead of kind of conflicting with their movements and causing ongoing symptoms. And if not treated, those symptoms can linger or recur and be an ongoing source of pain and limitation. Another potential source, which is much less common, would be disc pain, and there are different entities within that, but people can start to develop disc pathology if their muscles are dysregulated over a period of time. So really important, even from that first type of back pain, the muscle and tendon pain, to restore muscle function and coordination to avoid having excessive stress and strain on the lumbar discs. The muscles, I think, act in a protective way to the other spinal structures, including the discs.
For sure. I love how you said that. And I love the emphasis on muscle and tendon as well. One of the things I wanted to ask you, only because I came across this in our studies over the years in physical therapy and beyond, was that most people over the age of 25, 30 probably already have a disc herniation and don't even realize it. Is that something that you've also agree with or come across?
Yeah, we will see on MRI that with all the lumbar discs, L1 through S1, there may be varying degrees of what we call disc desiccation with loss of hydration of the disc, and there may be some bulging or protrusions or herniations. Those can all be fairly synonymous. A small degree of disc protrusion or bulging is generally not going to cause symptoms. It's generally not a problem, especially if the muscle control of the spine is maintained. If there is an actual extrusion, so some of the spongy inner disc material comes out, now that can create a lot of inflammation. That would be generally something that a patient would notice acutely. It may or may not put pressure on the nerves, but it can create a lot of inflammation. But fortunately, that does have a good capacity to resolve over time.
Yeah.
And in treatment with reducing inflammation, again, strengthening is all important. So in answer to your question, I think that, yes, there can be asymptomatic disc protrusions. So if we see on an MRI that there are present disc protrusions, either neck, cervical, or low back, lumbar. It's not necessarily a big concern. It's not an indication for surgery. It is something that we accept, and we don't want to necessarily respond to the MRI alone. We really need to take into account the patient's symptoms.
I'm so glad you said that, because some of my friends who are radiologists will often tell me, listen, Jerry, if you have a patient who has an MRI and that shows that they have certain symptoms or certain pathology, if it doesn't necessarily correlate with what you see clinically, then treat it clinically as you would based on what you found through your evaluation. Because oftentimes with a disc herniation, it may be asymptomatic and not the root cause of why the person has back pain to begin with.
Exactly, yeah. So there can be some potential for distraction from the real treatment in terms of pursuing interventions that may or may not be best indicated for a patient. So within my practice, my treatment goals for a patient are to really understand their symptoms. What do we think it's evolving from? Only really try to get MRIs when that would make a difference in the treatment pathway. Would this introduce role of injections or not, kind of thing? Or if we're looking for pressure on nerves. Sometimes there can be conditions that masquerade as nerve pain if someone's spine is not well aligned and they have a tendency to be what we call positively sagittally imbalanced or leaning forward. That can just put a strain on the muscles, and it can cause pain and discomfort for standing or from standing and walking for periods of time.
Right.
And that can act very similar to a condition called neurogenic claudication, where there is heavy pressure pain in the back, in buttocks and thighs typically, that builds up with standing and walking. So if we're thinking along the lines of what we need to figure out, is there pressure on nerves or not, an MRI certainly there could be indicated. For
sure, yeah. From a physio point of view, when we take a look at back pain, I would say more times than not, what we find is that there's definitely a relationship between how the rib cage and the pelvis line up. Obviously, the habits and lifestyles of the person that is before us, and any kind of history of past trauma or even previous low back pain for that person. And we find that oftentimes when we address the pelvis and the rib cage and we get that into what we call stacked position, that helps to optimize not only movement, but also the range of motion of the spine and the extremities as well, which can sometimes often mitigate the pain that patients have in the back. And I think you and I spoke about this before, just learning how to breathe appropriately, where a lot of people just come in breathing either through the apical segments. They don't realize how to expand the rib cage in a three-dimensional way and just only focus on diaphragmatic breathing, for example. These are ways that might sometimes destabilize how those muscles work to support the spine.
Yeah, in our kind of world, we talk about head over hips over heels, which is probably an oversimplification of how you view it, but it is important to maintain that spinal balance. And I think if something is out of balance, then muscles will try to compensate. And if there's a muscle that's always on tension because the baseline posture of the spine is off, then that is certainly a source of either inflammation and pain or potential loss of motion in the other direction, because it's compensating through either joints or through muscle tension to maintain the alignment. So I think the powers of breathing are beyond what we appreciate, and I think being able to have that kind of uninhibited respiration is important for us in many ways.
Now, among the clients that you've seen over the years, Phil, as far as what people have tried that has been successful for them to get out of pain, what are some of the things that people have mentioned to you that, I've tried these things and they actually helped?
There are treatments that I think can be beneficial to subsets of patients, and it's hard to predict if we're talking about physical therapy modalities. I think that some people respond best to strengthening the muscles around the spine in general. That's where I kind of prioritize, but people rely on regular dry needling, for example, or some people have benefited from acupuncture, and I understand there's a difference, but I'm not licensed in either, so I wouldn't talk about it further. But other modalities in terms of hands-on treatments, can be really helpful to increase blood flow, try to address usually muscle and tendon type symptoms. Injection therapy is something we've touched on before. I think that's best suited to treat nerve pain from inflammation, so what we call radiculitis. The inflammation can be from the disc, potentially from muscles, but oftentimes nerve pain, either down the leg or from the cervical spine down the arm, is something that can be very limiting, and an injection targeting that specific nerve is generally a safe and effective way to try to reduce that nerve pain or that radiculitis. I think that there are different types of injections that are done very frequently, but in my view, one of the strongest indications for injection therapy is for a single distribution of nerve pain. Other treatments, people talk about some of the modalities like electromagnetic therapy,
Sure. Yeah.
laser therapy. I think those are all worth a try for someone who is at least invested in strengthening, and if they're not able to adequately reduce their inflammation or reduce symptoms, to be able to kind of overcome the symptoms that are limiting them, then trying some of the other modalities would be helpful. But again, I would always prioritize kind of functional strengthening around the spine or other joints if they're causing pain.
I think that's why I appreciate you so much as a spinal surgeon talking about this, just because we are definitely a movement-based practice. And yes, we do use things like dry needling. We do use things like manual therapy, even shockwave, to help to accelerate that healing process. And for us, it's a phase one. We've got to get you out of pain so that the real rehab can start. And I think that, unfortunately, a lot of my colleagues out there, for one reason or another, they do use these modalities and maybe prioritize those a little bit too much. And that takes away from the client, I think, in the long run, because if we don't teach them how to move well, we don't help them to strengthen the right muscles over time and to loosen the right muscles over time, and joints for that matter, they're really not going to have the best long-term outcome, just because we know from the research, too, that exercise in and of itself has been shown to be very effective in managing low back pain. And so I'm hoping that if you're in the audience right now and you're hearing even someone esteemed like Dr. Phil talking about how exercise is a big component of helping you to have a long-term outcome that's really suitable for where you want to be in life, if you have low back pain and have been suffering from that for a long time, make sure that you are definitely incorporating that into your daily activity. Obviously, if you don't know how to do that, or if you've been sedentary most of your life, or maybe you move too much, it's always good to have the guidance of someone in the healthcare world who has had experience with low back pain and can guide you along the right way.
Yes, I agree entirely. I think that people come in from a different perspective. Some people say, yes, I'm very active. I'm around my job, my home, I'm carrying things, I'm lifting, I'm not sedentary, I'm not deconditioned, but there can be harmful levels of activity also if the muscles that need to support the spine are relatively deconditioned. I think that muscle and tendon pain can kind of work in some ways kind of like the tipping point phenomenon, where you may be asymptomatic for a long period of time, but then eventually the inflammation builds up and then one's in a painful state where those muscles are dysregulated. So I think it is important to have that constant, diligent effort with strengthening, and it can be something that's 10 to 15 minute activity each day, but it should be each day or most days to keep those muscles strong. And this is abdomen, low back, hip flexors, hip abductors, quadricep muscles even, can be done with just body weight exercise, but having that constant drive to strengthen and engage those muscles, I think could keep most people out of problem and allow them to do what they want to do overall. I also encourage low impact core strengthening, low impact aerobic conditioning also. And people who are able to do higher impact activity, including running, is generally okay, I think, as long as those core muscles are strong and equipped to protect the spine.
Yes. I'm not sure if you knew this, Dr. Phil, and if you did, pardon me, but running is by far one of the most core demanding exercises out there. Just because, and if you're a runner out there, you know what I mean, because for every step that you take, it's 3 to 5 times your body weight. So your body has to be able to remain upright on each limb over time. And if you are running out there, you are definitely engaging your core, so don't feel like you aren't. And I think Dr. Phil mentioned a lot of other exercises that are very beneficial to helping maintain a strong and healthy spine. Also realize that things like squats, deadlifts, all these exercises that Dr. Phil had mentioned are all beneficial. Just making sure that you are doing those correctly and making sure that you have the right form is really, really key. So whether you go see a personal trainer who really knows what they're doing, physical therapist knows what they're doing, or a physician like Dr. Phil, making sure that if you haven't had any kind of guidance before, that getting a professional look at what you're doing, what you can and can't do, or how you should progress is going to be really, really critical in helping you on your journey.
Yes, I would say maybe one point where we differ, I would be very hesitant to recommend squats and deadlifts to someone who is, at least in my office, who is in kind of a painful or limited state
agree.
at that time.
Yeah.
I'm not saying they're not right for others, but it's not where I would start. I would try to do exercise that engages those muscles, but not bearing weight through the spine.
Mm-hmm. Got it. So, Dr. Phil, let's talk about I think this is a very interesting part of your side career here. Not only are you a renowned surgeon, but you also, because you're a believer in movement, have a workout group that you started sort of on a whim, but has really started to grow quite a bit. Can we talk about that?
Yes. So I had goals a few years ago of how can I increase personally my own push-up and pull-up numbers, because I've always valued body weight exercise. Realized at some point a long time ago that I'm never going to be able to lift a lot of weight, and I wanted to avoid injury to joints and otherwise. So I became more kind of into functional fitness. And one day in the operating room, towards the end of 2019, I believe, I was with a group of people that we commonly work together, and just asked if anyone was interested in doing some sort of push-up or pull-up endeavor. And that gave birth to essentially what we now call the Bod Squad.
Love that,
and
the Bod Squad.
It is a small group of people who do workouts independently, but they have an accountability by being in this group together. So they will report when they've completed a workout, but not be forced to work out at the same time, same place. So it really hopefully would work into anyone's schedule. And the goal is really to get people active on a regular basis. So it's built to be 4 workouts a week, lasting 20 to 30, maybe 35 minutes for some of them.
That's cool.
And they are body weight exercise based. It requires generally some way of doing pull-ups, but then otherwise push-ups, and then some jumping and core exercises, as you've heard me describe, a heavy influence on the core strengthening. So it's at-home exercise that, to me, doing them still, it kind of pushes me every time, every workout.
Yeah.
I think it's fulfilling in that way. And then just the regular reps of getting these in, and the accountability to maintain on schedule with it, because your friends, your other squad members are doing them and reporting back. I think it's been a good thing, and I've seen some dramatic turnarounds for some of the members, the participants, where they were very sedentary and kind of losing their fitness, or had lost their fitness, and now people are running when they never used to run, doing triathlons when they had never imagined doing that in the past. So it's been, I think, a good way for people to form a fitness habit and a fitness lifestyle.
Yeah. I think my main role as a clinician is that accountability piece that you mentioned, and it's helping people to stay the course on rehab, because it can be long sometimes, depending on how long someone's been in pain for. And whether it's fitness or physical therapy, just having that person there who can keep you accountable. And maybe it's not even something that you're doing per se or saying, but just having a group, like you said, that, hey, I'm just reporting to you that I've done this thing. That helps to keep people sort of in the game, if you will, and consistent with the behaviors that lead to success.
Yeah, and now we have some people who have succeeded and continue to be walking kind of role models for the program. So I'll have friends come up and say, hey, how did you make this guy look like this? I want to look like that. What did you do? What was the secret? So I said, well, let me send you some workouts.
So it starts from there. What do you think this is going to go, the Bod Squad?
I would like to make it more available. I don't know that it is the perfect workout plan for everyone, because everyone has different goals. But
Sure.
I think there is a large part of the population that, maybe it doesn't have to be exclusively men, but people who have kids, have jobs, and used to be athletically involved, but now have other priorities, focuses in their life. And, each day they get a little bit more distant from their prior fitness levels. And so if we can kind of give them a new start point and say, here's a 20 to 30 minute workout that you can do at home. Maybe you do it earlier, maybe you do it late or in between kids' activities. I do it at the playground sometimes when I take my daughter to soccer. I mean, you can fit it in many ways. And so it's flexible in that way. But again, the accountability and just the regular efforts not to work out feverishly for 2 weeks and then get really sore and never work out again, but just to do kind of a gradual progression, and the workout system kind of builds as you develop familiarity with it and build up your strength. It's scaled to your current level of fitness. So there's a little test you do at the beginning. How many push-ups can I do? How many pull-ups can I do? And for people that can't do pull-ups, you can use an assist like an elastic band or use a TRX type strap and keep your legs on the ground so you're only lifting part of your body weight. So there's ways to make it really work for everybody.
I like that. And what's great about that is that people can go at their own pace and do it on their own time. And I think sometimes people get stuck on I have to do this thing and I have to go to the gym for, X amount of time. And that becomes a hang up for people because if they don't get there at that time, I didn't work out, and then the downward spiral happens again. But I love that you have this system where people can just do whatever they want and wherever they want to. And it's just about the consistency over time that really matters most.
I agree. Yep. That is the goal. We're trying to develop that habit, that fitness habit, and say, I want to do this workout today and I feel good after I do it. And I want to be able to check in with my team and encourage them, through the squad that way. So maybe there's a platform you could probably help me because that's not my strong suit, but a platform out there that already exists to try to increase awareness and help others to enhance their own fitness.
Yeah, we can definitely start a channel or something like that. I'm looking forward to helping you out with that.
Cool. Got to get you in a workout first.
Oh, yeah, absolutely. I'm down. I'm game. So before we go into your area of expertise, I do want to talk about your history in triathlon because, as you know, we do have a triathlon club, and a lot of our clients are either triathletes, runners, cyclists, or swimmers, among other types of athletes. But tell us about your history doing it because you're like killing it at the long races, which is amazing. You're self-coached. But talk about how you got into triathlon.
So my youngest sibling, my sister, is an avid swimmer and started doing triathlons probably 15 or so years ago. And she does a lot of open water swims. So she invited me to do a triathlon with her, which was very close to where I lived in 2007. It was my first experience. I didn't have a fancy bike. I was gym shoes on pedal, right? And it was something that I knew I wanted to do and I probably could do. So I trained a bunch for it. Had a goal time in mind, which is not necessarily that important, but I did. And had a great race, a great day. And I think I cried after I realized I got my goal time. I was just so happy. I was elated by it.
Amazing.
And then started residency after that. So I didn't really see much triathlon. Well, then we had our first kid too. So that was a little bit of I would say distractor from triathlon, but probably for the best.
Yes.
And then at some point, several years later, got back into it and did 3 more. So I always knew I wanted to have that or could have that and would be potentially something I enjoyed in my life, but I had some kind of starts and then stops. But in 2022, last year, I talked with my wife and said, I want to give this a go. So I signed up for a bunch of races, international length, sprints, and then my first full distance Ironman race. And like you said, self-coached, I kind of came up with something. I picked up tips from people along the way at other races. One guy said to do a full distance race, you should ride at least 6 century rides in preparation for that. So I had that in mind and said, okay, I'm going to do my 6 century rides, and would go to local bike shop and get some tips from the staff there and just try to put it all together. And sure, I was anxious about it. I had some self-doubt, I guess, but overall, I think I knew I could do it and wanted to do it. So, it's been fun. I hope I can do more as long as I can fit it into family lifestyle and
business
and this new practice. Yeah.
Well, I think, what you have not yet mentioned, Phil, is what your time was, because that for anyone who's done an Ironman out there, for this guy here, Dr. Phil, who is self-coached, tell us about your tell us about your race time for your Ironman.
So I had a goal around 10 and a half hours, and I achieved my goal.
Yes.
So
Amazing.
I was very happy about that. There's a lot of factors that go into play. I mean, one is, all components of the race, trying to maintain an aerobic level of output, so to speak,
sure.
so you can maintain your kind of clean burning metabolism so you don't cramp up during the run. It's all about getting to the run to finish the run.
Yeah, exactly.
You can bike really well, but if you don't leave yourself in a good position to be able to run the marathon, then your race is not complete. So I really focused on my own race plan and pacing, and I'm probably, average at each of the events, but it all works out being okay.
Okay. Oh my
So
God. Very humble here. A little too humble. It's an exceptional time if you don't know out there. And for somebody who's not coached and only your second or first time.
that was the first.
That's
yeah.
just crazy, man.
And I've done two more since, and my times have been right around. I was hoping to improve, but I'm pretty stable at that time.
Well, I can only imagine what's going to happen over time, of course, but also if you did get some coaching, my God, it'd be crazy to see how you would perform.
Well, maybe. Are you a coach? Is that why you're?
I am not. I am not a coach. I am not a coach. I have coached beginners, but I'm definitely not a coach. But that's great, and
Thank
I
you.
want to, absolutely, and I'm looking forward to getting on some rides with you, and I'll try to hang on to you because you're probably better shape than I am for triathlon right now. But let's go dive back into your area of expertise, because people often ask me, well, if we've tried everything and we're still in unremitting pain, or we have some severe dysfunction as a result of back pain. Maybe even a drop foot for people out there who might have had that severe disc herniation, and you're absolutely debilitated. What's the next step for that person? They've tried injections, not working. How do people out there decide that surgery, or how do physicians at that point decide that surgery is the way to go? And what are the options that people have out there?
Yeah, great question. So we had talked about different types of back pain. We talked about the muscle and tendon pain, disc pain. There's potentially other causes as well, but then there's also the potential for nerve pain, which can be associated with that. And oftentimes nerve pain can cause radiating pain down to the lower extremity, buttock, or down the thighs and calf to the foot even at times. There's also types of pain where the whole nerve sac is compressed, and that can cause more of the diffuse heavy pressure pain with standing and walking that we had mentioned earlier. So if there's an element of nerve pain, nerve compression, that could also have an associated nerve weakness or numbness symptoms associated with it. And nerve pain, weakness, and numbness, what we call radiculopathy, that can be very debilitating. Oftentimes it can improve over time with conservative treatments like strengthening with physical therapy. Injections can help the pain part of it generally. Certainly medications can help to mitigate symptoms. But if the symptoms are ongoing, or if there's, as you mentioned, a functional weakness that's limiting somebody or worsening, then taking pressure off the nerve surgically may be the best solution for that patient. So if there is pressure on nerves from a disc herniation or a crowding of the nerves, but the spinal alignment and the structure is overall maintained, then a decompression procedure could be the best solution for that patient. So that could be a small focus surgery to either remove a piece of disc or open up the space for the nerves to traverse through. And that's not using implants. It's not a fusion. It's not placing screws and rods. And so that type of surgery generally can be done either as an outpatient or fairly short hospitalization if patient's healing well, and does require strengthening afterwards. So I prioritize strengthening postoperatively, just as I would for someone trying to avoid surgery in the first place, to help re-engage the muscles, because generally surgery will always go through the muscles, even if it keeps the muscles on the spine, like our more minimally invasive strategies that we currently use. It's still important to re-engage them, recondition, because someone's been limited prior to surgery from their symptoms in the first place. So an extensive course of therapy transitioning to an independent exercise regimen, I think is important, and that should continue indefinitely.
Yeah, for sure. Now, Dr. Phil, as far as like the procedures themselves, are ones more complicated than the others? Like, what are the most complicated procedures you have to do? Is it usually related to trauma?
The complication, well, I hate to use the word complication, but the complexity of a procedure can be dependent on patient factors. It could be dependent on degree of pathology. So there's something called a spondylolisthesis, where one vertebral level is slipped forward relative to another. It's a very common pathology. Most often we see low-grade listhesis, grade 1 or grade 2.
Dancers, gymnasts, figure skaters are among the ones I've come across. Javelin throwers too.
Yeah. There can be the isthmic spondylolisthesis at the lowest level, L5-S1. That can result in pressure on the L5 nerve. So a structural problem in the spine results in nerve compression. And so surgery can be an excellent solution for that, if not getting better with strengthening,
right?
Possibly injections, activity modification. So if there's a higher degree of slippage, or if the angle of the sacrum is steeper, then that can make a surgery that otherwise could be a pretty routine surgery. It can make it more complicated. And some of our newer technological advances like robotic surgery can help with that. So we can still provide a high-level surgery with accurate screw placement and safety for the patient in a difficult or more difficult setting. Scoliosis surgery is generally larger surgery, fusion over many levels to help control and reconstruct the alignment of the spine. Oftentimes there may be what we call dysmorphic pedicles, where the tracks that we use to place the screws are very small, not formed appropriately. And again, I think that's another instance in which robotic surgery can help optimize our accuracy and our fixation strength. It's number one about patient safety, and number two about doing a good job that we set out to do for the patient. So I think that there can be challenges. We encounter those regularly, but we have to continue to do our best to focus on safety, doing a good job, and getting people to heal well and getting that desired level of function back.
That's great. Now, for people who maybe surgery was the last stop and they went through the surgery, have you had people just not get better even after surgery? In other words, there's no guarantee even after surgery that they're going to be able to return to function because of many different factors.
There are. It depends on the underlying cause. So if someone has pressure on their spinal cord, that can cause loss of lower extremity function and ability to walk. And if that's occurring at the cervical spine, the neck, it can cause loss of hand function. The goals of surgery there are to really prevent from further worsening. So it's not always that patients get good return of function following. We try to catch that early, and so we don't get into the situation where they have a lot of functional limitation. There are other times where if someone has even a disc herniation in their lumbar spine causing a foot drop, that's not always a guarantee that that can come back. So there are instances where there's definite neurologic weakness or functional loss that may not always get better after surgery. And then there's a question of patients have pain and they have a spondylolisthesis, that slippage, and surgery goes very well, but they just don't respond to it, or they have some other pain that may come from a different source. Could be inflammation. There's no pressure on nerves anymore. Everything looks good structurally. Yeah, so we are always, on our toes, so to speak, to try to keep patients kind of moving through appropriately, and strengthening, I think, plays into that to help reduce inflammation. But if someone is not responding as we would hope and anticipate, and as they would hope and anticipate, then we would make sure imaging looks okay. We would make sure that we're addressing everything, considering other factors. But the decision to get to surgery in the first place really should take into account all of those things.
Right, to begin with.
We know we need to be sure that we are treating the level of pathology that's contributing to symptoms, and that really helps to enrich our success rate and make it very favorable for patients in the first place.
Right. Now, do you find that certain kinds of personalities, for example, may fare better after a surgery? And what I mean by that is I've come across certain people, patients in my lifetime career, where they are hypersensitive people. And as a result, sometimes things like surgery don't necessarily go that well, or any procedure for that matter, because everything's been magnified symptomatically. Have you come across those kinds of clients too?
I think I know what you're describing. Yeah, I think people and their mental approach can affect their functional response in some
Sure.
ways. Sometimes it may be actual neural or neurologic differences. So yeah, we've seen all shapes and sizes, so to speak, and all sorts of responses. I'd say in general, most people respond predictably and respond well when the indications for surgery are good, and the surgery itself is done in a appropriate way. Then patients do have generally a good response, and maybe a little bit more in terms of someone needs more or less pain medicine, or for longer or shorter. But I'd say that fortunately, there's not too many outliers.
Sure. From that, yeah. Now, as far as like things that you recommend patients do after surgery, and I know you and I are not nutritionists per se, but do you ever find yourself either recommending certain kinds of intake of food or macros of that nature to help expedite healing?
I do talk about that sometimes with patients. It's certainly something that I do believe in. I think how we supply our body to especially heal after a large taxing event on the body like a surgery is important. So I'll mention healthy diet. People have their own dietary preferences, and I'm not going to say specifically what to do, but just to be mindful. I often say drink only water, in terms of avoiding anything sugary or sweet, or, diet beverages that may have other components that may limit bone healing potentially. And it's hard to prove any of those things, but it's just, I would start with healthy building blocks. I would try to have a reasonable amount of nutrition, not overdo it. If there's a patient that is diabetic, then we are very strict in terms of their intake perioperatively, because we want blood sugar to be well controlled to promote healing for them. So yeah, it's really going to be a personalized discussion based on that patient.
Now, for people who have had surgery, at some point, are they necessarily going to need to have surgery again, Dr. Phil? Or typically is it once you're done, it's done unless you do something that were to be sort of traumatic to the spine?
Yeah, that's a good question. And I hear that a lot from patients, because some of the reputation of spine surgery is that, hey, this may lead to more surgeries. And I'd say the majority of patients and their pathology we can treat one time and have them heal well, and they not need anything further. But there is a concept of adjacent level degeneration, where if a spinal level is fused, then the level above may experience more stress and strain. So over time, that could degenerate and cause symptomatic nerve compression or instability. And that could be indicated for fusion again, or additional surgery. If we're talking about a disc herniation, and that's treated with a microdiscectomy, or the decompression I mentioned earlier, there's about a 10% rate of a recurrent disc herniation, which could become indicated for additional microdiscectomy procedure. So it's always possible. There's many spinal levels. Usually, if you do a discectomy, there's more disc in there that you want to maintain, but it's possible that could herniate again. So we try to treat someone with a surgery, because surgery is a big deal. We don't want to put people through multiple surgeries. So how do we best treat their current symptoms? How do we potentially foresee anything that's going to cause a problem in the future and put them in a position to heal well, but hopefully this is their only surgery.
Right.
And so there will be some patients that have changes to the next level. We would go through similar treatments to try to strengthen, but really the role of the initial post-operative strengthening to help their spine be supported, prevent that excessive strain on the disc, or if it's a discectomy procedure, strengthen so there's not that ongoing stress on the disc that would cause a recurrent herniation, to avoid additional pathology and pain and the whole process leading to surgery again.
That's awesome. We're actually going to be, I've used this in the past, and we're going to bring the technology here, but for those clients of ours who maybe have trouble activating certain muscles, there's surface EMG that we can use during activity to make sure they are firing the right muscles in the spine, or supporting the spine, and also the muscles in the gluteals and whatnot, so that we know for a fact that they're actually using those muscles, engaging them during exercise, and they can actually see the biofeedback on a screen to make sure they are actually doing this correctly. There have been a couple stories where we've had clients where they've had pain during back deadlifting, for example, and found that they weren't really using one side of their spine as well. And once they saw that, they recognized that they were able to start adjusting and becoming aware and contracting those muscles, and the back pain went away, which I thought was really interesting. But that's something we're actually bringing back here.
That is. Can I ask about that a bit more? So that could be a very helpful tool. Traditionally, spine surgery was done through a long midline incision that would involve lifting up the muscles from all of the bony landmarks there to help place screws or do a decompression. Our current techniques allow the majority of that muscle to remain in place, and we can work through the muscle. So would there be a difference if we could use that tool to study a minimally invasive postoperative patient versus one with a more traditional surgery, or, before and after their own control, before and after surgery? Do their muscles actually maintain function, or do they have a deficit in some of the smaller muscle groups?
That sounds like a fun case study.
Yeah.
We should definitely collaborate on that.
Let's do.
So that's great. And Dr. Phil, as far as other things that you might recommend clients do, aside from physical therapy, have you found any benefit from clients trying things like Pilates or yoga or other kinds of exercise modalities?
Yeah, I think depending on the patient's background, their comfort, familiarity, their limitation from symptoms, I think yoga and Pilates, they are things that I mentioned specifically, and those can be fairly broad terms and mean different things to different people. But I think the emphasis on core strengthening and maintaining balance between two sides, front and back, opposing muscle groups, I think that's very helpful for the spine in general to help minimize symptoms. So if someone is having an acute episode, I would generally have them work under the guidance of a physical therapist, but transitioning then to an independent program. And a lot of those exercises may be fairly simple, maybe uniplanar type exercises, single joint, but then broadening into more of a yoga-based program that may be a little bit more complex or utilize coordination of muscle groups and be more interesting to them over long term, I think is very appropriate.
Got it. That's cool. Now, I want to dive into one specific diagnosis, which is spinal stenosis. And the reason why I wanted to bring this up on the show is because we've had patients in the past have this. And I have to say, admittedly, over my 22-year career, I'm going to say that more often than not, they actually required surgery at some point. And we did everything we could conservatively and just didn't work. Do you have an understanding of why that might be the case, as far as why a degenerative spine might not respond well to physical therapy?
Yeah, I think that stenosis, which means narrowing, so spinal stenosis is narrowing around the nerves generally. If in the lumbar spine, that can compress the nerve roots and cause heavy pressure pain, back, buttocks, and thighs that make it hard to stand and walk. If there's stenosis up higher in the spine, it could put pressure on the spinal cord and causes difficulties with walking, or if in the neck with hand function. So physical therapy to help strengthen the muscles, support the spine, reduce inflammation, could help reduce some of the neurogenic claudication symptoms from the lower back, from the lumbar spine in the setting of stenosis, but it's not going to actually make more room for the nerves generally. But a lot of times symptoms can be driven by an inflammatory component on top of the stenosis or the narrowing. So if the strengthening can help to avoid more stress and strain on the discs by promoting appropriate alignment, that could potentially result in a little bit more space available for nerves, could also result in less inflammation generated by the disc. So you may be able to treat patients successfully in a large percentage of cases. And I've seen some patients with MRIs that demonstrate a lot of stenosis, but they're walking around
totally
like
fine, right?
Nothing's bothering them.
Yeah.
And probably patients can be asymptomatic with that for a while, but if it does then flip over to becoming symptomatic, then, how do we treat that? Do we add in an injection to try to reduce some of that inflammation, continue to strengthen? But yes, it may be, again, that surgery to take pressure off the nerves to address the stenosis could be the most effective solution for that patient.
And it's, to my understanding, it's not a terribly invasive surgery, having basically opening up the narrowing of the canal.
Yes. Again, if it's just stenosis being treated. We have to look at what is contributing to the stenosis. Is it generalized narrowing around the nerves? Is there a large component of disc herniation? But it could be treated with a minimally invasive type surgery or a micro decompression, in which we remove a little window of the bone overlying the nerve canal, and usually just the inner part of the facet joint. And that creates enough room for the nerve signals to pass through and to be asymptomatic.
That's great. Now, I want to get back into discectomies. What actually happens? Can you kind of walk through that surgery? Because we've had a number of patients who've had that in the past, and many of them are successful and for long term. Tell us about kind of the surgical procedure itself and what patients should expect.
Yeah. So in a setting of a disc herniation that results in pressure on the nerves, it usually occurs towards the side or the periphery of the canal. So it's usually a midline incision and then work down just on that symptomatic side. Again, make a little window in the bone and work around the nerve sac to protect the nerve sac. And the disc is in the front and we work from the back. So we have to kind of work all the way around circumferentially. And at that part of the spine, we can retract the nerve roots gently, but we can move them out of the way to see the disc that's in front. Sometimes the piece of disc is, I'll say free, but it's come free from the disc. It's an extrusion, but it's not freely floating in there. It's kind of jam-packed, and it oftentimes doesn't really want to come out. So you have to coax it out and make sure you get all of it to come out, but protecting the nerves as you go. That's the most important part. And then sometimes the disc herniation is a protrusion. It's still contained within the disc. So you make a little nick in the disc itself and then remove just the protruded portion of the disc. The goals are to remove all of the disc that's unstable because you want to avoid a recurrent herniation, but leave as much of the stable disc as possible so they still have a functional disc. Because some patients undergoing the surgery are very young and want to be active again. So it's the goals of treating the current symptoms, preventing anything hopefully from herniating in the near term in the future, and then leaving them with a functional disc. And then we would generally have them be very light with their activity after surgery. So first few weeks, just building up walking, neutral spine. They'll be taught no lifting, no bending, no twisting. That will hopefully avoid any eccentric stress across the disc, which could encourage a recurrent herniation. So once they get through the first few weeks, then we would start a more guided physical therapy program to strengthen. So active strengthening. And as you strengthen, all those restrictions can be relaxed. And the goal would be to get back to a full level of activity unrestricted in time with appropriate reconditioning of the core muscles.
Now, surgically, once you've cut that part of the disc out or minimally invasive surgery, do you then cauterize that area? You sort of burn it off, or or just leave it as is?
We leave as is. There have been many studies done of how can we patch this, how can we suture it, companies, how can we sell something to help us with this. So we call it irrigate, but we'll use just saline fluid to make sure there's no other pieces of disc that want to come out, and then try to keep that, what we call annulotomy, that nick in the outer disc covering, as small as possible, because that does have a relation to potential for recurrent disc herniation. And we'll see over time, if someone gets an MRI in the future, that will heal up or scar over. It won't be an ongoing opening or annulotomy in the disc. So
I know in the past, I don't know if they still do this or not, but they would actually kind of go into the nucleus and almost like burn it so that none of the material inside would actually come out further. Is that still done?
That is not done, no. Okay. But things like that had been attempted to, again, prevent recurrent herniation, maybe try to reduce some pain from nerves around the disc and the vertebral body, but mostly I think to prevent recurrent herniation. But I think that's higher risk than reward in that setting. Got it.
Dr. Phil, thank you so much for sharing all that amazing knowledge. So let's get back to racing and triathlon. We always end on this note because at heart we are foodies, and that is why one of the reasons why I like to work out, because I love to eat. Tell us about your favorite race foods, like post-race foods, or like this is my go-to. I have to have this snack daily, or I have to have this after a race.
Ooh, that's a hard question. So,
So many
that's
choices.
changed in the last year because I am now gluten-free. So I previously would love pizza even after races, but now I can't touch it. But they had pizza after my most recent race, and I don't know, honestly, if I would have been fit to eat it because the digestive tract is not exactly working normally at that point. So
Yeah.
during the race, I try to balance, obviously, hydration, try to get some complex carbohydrates. I will make and bring peanut butter sandwiches with me during the race.
Sure.
Of course, nutrition stations at the event are very well maintained, and just try to keep up my caloric load that way appropriately. But afterwards, I'll try to ease back in. I think I ate a burrito bowl after this most recent race.
Yeah. That's awesome.
And I think I had a quinoa bowl after a race 6 weeks ago. Just something like that, a little heartier, but fairly bland, and a good mix of, all the macros, but get some vegetables going, because usually after a race, one has eaten a lot of sweet things all day, from the Gatorade to the gels.
Yeah.
And exactly. It's like, let me brush my teeth and let me get something that's maybe on the more savory side, if that's a word.
Absolutely. Yeah.
I am not a foodie, by the way.
You're not. So you eat to live. You don't live to eat.
I identify with what you said about working out. If I work out hard, I'll be like, now I get to eat whatever I want for a while. But it's usually pretty simple things.
Really?
Like, I'm going to make a really big salad.
Oh, man. That's not fun.
I'm going to eat a lot of oatmeal. Are you going to turn me off now?
I guess that's right. Oh, man. Well, Dr. Phil, thank you again for coming on our show.
Thank you, sir.
Yeah, I'm looking forward to building a relationship and seeing how we can help each other out as far as making sure that we have the right recommendations to you and vice versa.
Absolutely.
What's the best way that people can get in touch with you and find you? You're in Cary here at your office in Cary,
yes,
as I know.
Cary, North Carolina. PremierSpinalSurgery.com is our website. It's in development. Hopefully it'll be very helpful. But yes, PremierSpinalSurgery.com.
Great. And for any of our listeners, if you are in the Cary, Apex, Morrisville, or Raleigh area, again, one of the things I really appreciate about Dr. Phil is that he's very conservative, but he also lives out what he preaches, and he's really about trying to get people to live a better life and do everything possible before having to go under the blade. And I think that, unfortunately, that might be on the rare side these days in the field. And so for me as a physical therapist and seeing the value in helping people live that kind of lifestyle, also meeting somebody like Dr. Phil, where that is also very important to him, both professionally and personally, I think it's a great match for us. So again, very excited to start on this friendship and seeing how this goes.
I too am excited about the collaboration, and I'm feel blessed to have met you. And
likewise,
thank you for introducing me to my first podcast.
Yeah, you're welcome. Great. On that note, see y'all later and have a great day.
Thank you.
Thanks so much for tuning into today's episode. It really does mean a lot to us. And don't forget to like, share, subscribe, or comment if you got at least one or two helpful insights or takeaways to help you get to your next level.